your host today. As usual, your lines have been muted upon entry to this webinar. Unless you're presenting, please keep yourself muted. There are other ways of interacting using WebEx features we'd like you to be aware of, like sharing a reaction. So if you click on the smiley face on your toolbar, that's one way to share a reaction, and we encourage you to use those throughout the meeting. Another way to interact during the webinar is using the chat feature. So please ask questions or have comments by typing them in the chat throughout the presentation. Just make sure you select everyone so we can all see what you're writing. And we'll keep track of any questions that come through and try to address them at the end of the presentation or at least within the webinar follow-up email. On the agenda today, we'll discuss the objectives for the presentation and then move into an overview of the award program and the changes you can expect to see in the 2023 application. After that, we'll head on to the formal announcements of the 2022 awardees and have each award recipient share more information on their project during the showcase portion. We'll end with sharing the regular QI opportunities available to you that you can participate in. Today's objectives are to understand the purpose of the MDH Stroke Quality Improvement Awards program, review the changes in the 2023 application related to health equity, discuss the benefits of collecting and using data for quality improvement at your hospital, and learn about methods and approaches hospitals took to conduct their quality improvement project. Before we jump into announcing the award recipients, we'll quickly review why we have this program and then the changes you can expect to see in 2023. For purpose, so we know that most of you are conducting a quality improvement project to some degree, and we just want a chance to recognize and share how hospitals around the state are tackling different initiatives because likely another hospital is trying to do the same thing that you're doing. This program aims to recognize and showcase successful quality improvement initiatives throughout the state of Minnesota's hospital-based stroke programs. On top of that, we also wanted an opportunity for hospitals to share their successful quality improvement projects and lessons learned, further a culture of learning and collaborating. And lastly, we want to encourage others to take on projects and also just apply. I hope that if you applied last time and did not receive an award this round, to not be discouraged and to keep applying. The same goes for if you've been thinking that your project doesn't quite qualify for the award program. I bet it does, so please email me. And know that we know that based on designation and site visit reviews that there are some amazing projects happening around the state that we'd love to highlight, but we need you to apply in order to do that. So the awards are given to hospital stroke programs that implemented the best quality improvement initiatives in the following categories, which are Continuous Impact Award, Operational Excellence Award, and Outstanding Achievement. And we'll view a description of each category during the showcase portion. If you're looking for more inspiration after today's webinar, please check out our Stroke Quality Improvement Awards page on our MDH Stroke Program website. You can read about 2022, 2021, and 2020, 2021, and 2022 award recipients. This is also where you can find information about the 2023 Stroke Quality Improvement Awards and find the new application. So what's new in 2023? Well, we've opened up applications early, so hospitals have more time to fill it out. You'll have from now until the end of August to complete an application. So this means a program could begin a project and fill out the application as the project progresses, as well as have more time to see results. Building on last year's application, we're now required that the health equity considerations be addressed this award cycle, and I'll speak more about this on the next slide. So let's go into some tips and tricks we hope will be helpful for the next application cycle. After reviewing the 2022 applications we received last year and creating the 2023 application, we thought we'd share some helpful tips that we've learned along the way. So the first tip is simply apply, apply, apply. Please apply for the program. Use the extended timeline to slowly work on this. Reach out to us for help, questions, running ideas past us. This is what we're here for. We aren't scoring on grammar or sentence structure. We're scoring on content, answering the prompts we've provided completely. We let you know everything we're looking for when we're scoring applications because it's all on the application. It's all in the prompts. So it's very straightforward. Something that we noticed there is a lot of variety in last cycle was in the settings section. So some applications incorporated almost all the suggested characteristics, and some just included more like geographical ones. We really appreciate the ones that included more than just like location information because it paints a more robust picture in which your quality improvement project's taking place. However, if you're only including geographical information because that's what you had available, we thought you could also draw from your designation site visit opening presentation as it has a lot of that information in it. We also encourage you to reach out to your hospital admin or your quality improvement department about your patient population characteristics, because this is usually information they have typically like readily available for you. And this is important because the uniqueness of your hospital is just a great place to shine, and we'd love to know more. And lastly, so now that health equity is an expectation, some of you may be like, well, how am I going to do that? Don't worry. We've added prompts that guide you through the process so you don't have to think about this on your own. You just need to respond to the prompts. And this is more about starting to think and apply a health equity lens to your work because it impacts quality improvement work and it can strengthen it by being more specific on how you address an area improvement or performance. So who do you need to focus on? Is this an issue for everyone or is it a subgroup of patients? Why is this the case? How can you best reach them? We want you to reach out to us if you feel like you're struggling and we can talk through some solutions. The main point is that health equity has already been incorporated to the application for you. So as long as you answer the prompts in each section of the application, you are good. No extra thought you need to add. Now we've come to the celebration portion of the webinar that we've been waiting for, the award announcements. It gives us great pleasure to announce there are 6 awardees for 2022. All award winners are designated stroke hospitals throughout the Minnesota stroke system. Most hospitals are located in the state of Minnesota, but this round we had 2 projects that partnered up with their colleagues in Wisconsin. And while not technically in Minnesota, these neighboring hospitals' initiatives positively impact many Minnesota residents as well. Our first category is Outstanding Achievements. This is being presented to Essentia Health, St. Joseph's Medical Center, and Regions Hospital. Our first, and the next one is Operational Excellence. This is being presented to Hudson Hospital and Clinic and Lakeview Hospital, their collaboration, and Winona Health Services. Lastly, the Continuous Impact Award. This is being presented to Allina Health Faribault Medical Center and Mayo Clinic Midwest Collaboration, which includes Rochester, Mankato, Eau Claire, and La Crosse. Congratulations, hospital. We will now move on to spotlight each of the awardees and hear a brief summary of their projects. We are lucky enough to be joined by every single recipient today, and here's a map showing where all the QI projects took place in 2022. We are pleased to see so many joint applications and so much collaboration this round. Our first category is Outstanding Achievement. This is an award for starting an initiative that created a meaningful and long-term improvement in quality of stroke care. To kick off the showcase, we have Essentia Health St. Joseph's Medical Center. They are a primary stroke center located in Brainerd, Minnesota. Joining us today is their ED manager at St. Joe's, Angie, who will be speaking on behalf of Elsie, their stroke coordinator. Thank you, Angie.
Good afternoon. Elsie apologizes for not being able to be here, but she had other priorities, understandably so. So thank you. And as she said, I'm Angie. I'm our nurse manager for our emergency department at St. Joe's here in Brainerd. Today I will be presenting our quality improvement project, Time is Brain, to ensure fast care to all modes of arrival in the absence of Elsie. Next slide, please. As a stroke program, we teach our community members time is brain and be fast. Yet primary rural stroke centers, we know the average about 50% of our community members drive themselves to the hospital rather than utilizing EMS when experiencing these stroke symptoms. We further know stroke guidelines state that early stroke management and ED can shorten time delays among those that arrive and improving our outcomes. The guidelines further drive the importance of establishing a process being in place for quick brain imaging on their first arrival to the hospital. Next slide. With this knowledge, after evaluating our stroke alert goals and our door to CT metrics and medians, we acknowledged that our door to CT metrics showed inconsistencies when comparing our arrivals by EMS versus private vehicles. Knowing time is brain and half of our stroke patients arriving by private vehicle, we focused on ensuring all stroke patients receiving quick and best practice stroke care independent of arrival mode. Our goal was to improve our door to CT time for patients arriving via private vehicle, ultimately improving door to treatment times. Next slide. To understand the root cause and the difference between our CT times for EMS versus private vehicle, and the alert process was reviewed in the emergency department stroke alert activations. More specifically, our door to alert, door to CT, and door to treatment times. Our St. Joe stroke program was already utilizing a 30-minute stroke alert time. Furthermore, the ED and EMS arrivals were already meeting, our EMS arrivals were already meeting our door to stroke alert goals. In summary, our EMS pre-alert stroke process included patients going straight to CT, where our private vehicle arrivals were immediately roomed, underwent a quick triage, and then transferred to CT. The private vehicle alert process was found to have a median delay time of 7 to 8 minutes from alert to CT. This data was shared with our unit council members, and mirroring our EMS alert process, we proposed and supported and communicated to all staff in the ED to mimic the same process. Next slide, please. The biggest challenge encountered during this project was initiating the proposed plan and to encourage staff that this goal and process was achievable and possible. The EMS pre-alerts and EMS stroke alert process specific to CT times and going straight to CT is always going to show exponential times. However, working with our team, we recognize stroke symptoms quickly, and activating a similar process for our private vehicles can and will ensure that the stroke patients receive the same quality of care. In the blue line, you can see our all stroke alert arrival, and then the green line is our private vehicle arrivals. With this graph, we can see our improvement from our door to CT median times, which we met for Q2. Slide. This table shows our current door to drug goal times, and so far in 2022, we've improved our door to drug times and the goal being met. Since initiating this and submitting this project, we've had many ups and downs, including delay in reverting back to old practices. Knowing the updates to our private vehicle is possible and showing our outcomes for our patients, we've encouraged and supported staff through reminders and updates with frequent feedback. Thank you.
Thank you, Angie. Thanks for stepping in for Elsie and sharing this great project put on by St. Joe's. To finish up the Outstanding Achievement category, we have Regents Hospital. They are a comprehensive stroke center located in St. Paul. And joining us today, we have their stroke coordinator, Carol. Thank you, Carol.
Thank you, Allie, and also thank you to the Minnesota Department of Health Stroke Program Team. So as background, you can go to the next slide. As background, Regents was the first to receive the Comprehensive Stroke Center certification in Minnesota. But despite all the achievements and efforts, we lost the Get With the Guidelines banner designation for advanced therapy in 2021. In simple terms, our timing for thrombectomies fell short. So we took a pause and looked back at what could be the root cause for this and found three main opportunities: early clinical diagnosis, timely neurovascular imaging, and large vessel occlusion or LVO detection. Most importantly, complex team communication. So the analysis revealed we were wasting time and losing neurons in the communication phase with 5 or more phone calls commonly built into the communication chain between the team members. We realized that the key solution to addressing our timing was, 1, have every key member in one communication space, and 2, have a lower threshold to detect suspicious LVOs. So we redesigned the acute stroke process around using Rapid AI software, not just because of using AI in early detection, but also because of its HIPAA-protected chat space, where everyone could see the images, clinical background, image interpretations, and information flow in real time. The software is linked with the imaging programs that we have. Code stroke imaging is labeled uniquely to be picked up by the app, and after the first imaging results are processed, they are automatically pushed to the app and the team begins communication. Next slide, please. So here's a screenshot of a case that arrived with pre-notification from EMS. The SNPs in the slide are read bottom to top and left to right. The green circles are highlighting the timestamps of key process steps like CT imaging results, CTA imaging, and activation of the mechanical thrombectomy team. So as you can see, there were many persons on this chat: neuroradiologists, neurologists, ED and critical care response RNs, neurointerventionalists, EDMDs, and neurocritical care MDs all participate in the chat. And what often took 45 minutes to an hour to activate the IR team for clot removal procedure is now closer to 20 minutes. Next slide, please. So here's a reminder of the criteria to achieve that advanced therapy Get With the Guidelines recognition banner. 50% of the ED arriving cases are to get to their device deployment in 90 minutes or less, and 50% of the transfer cases are to get to device deployment in 60 minutes or less. Next slide, please. This bar graph shows our hospital's median time to device in minutes for 3 separate periods. From the left, that first group is full year 2021, and in the middle are the 2022 cases before AI, and the third group represents the cases post-rollout. The green bars show direct arrivals, and the purple bars are the transfer cases. And the green bar, declining, represents around 20 minutes of time saved for those cases arriving directly to the hospital in the post-rollout period. Next slide, please. So this graph shows the same time periods and the remarkable improvement in percentage of cases that met the criteria for advanced therapy banner. We more than doubled the percentage of cases meeting the time goal compared to post-rollout when comparing post-rollout to the 2021 performance. Next slide, please. So April 6, 2022 was the rollout day for the mobile app, And for every month since, we have either met or surpassed the criteria for recognition, which is represented by the red bar. Take home for us was that horizontal communication is a key for acute stroke care, which is truly a team sport. If the typical patient loses around 2 million neurons each minute of untreated stroke, then in the months since April, with a reduction of about 18 minutes per case arrival to device times, that equates to a whopping 2 billion neurons saved. On behalf of the entire region stroke team, thank you for the opportunity to share this initiative.
Thank you so much, Carol, for sharing how regions approach this project and some great ideas. Yes, we have some claps. Lots of people are happy. We'll move on to the Operational Excellence Award next. This is an award for an initiative that focused on collaboration between different programs to improve quality of stroke care. To start off the Operational Excellence Award, we have a joint effort by Hudson Clinic and Hospital in Hudson, Wisconsin, and Lakeview Hospital in Stillwater. They are both acute stroke ready hospitals, and we have both, I think both stroke coordinators with us today, Krista from Hudson and Karen from Lakeview.
Thank you very much. This is Krista. I'm the stroke coordinator at Hudson, and Karen is on the line as well from Lakeview, the stroke coordinator there. We first of all Minnesota Department of Health immensely for the opportunity to apply jointly for this award, as well as acknowledging the work that we've done this year. So both Hudson and Lakeview are two acute stroke ready hospitals, and we're actually the only two acute stroke ready hospitals in the east side of our Health Partners family of care. And due to this, Hudson and Lakeview have learned to lean on each other and collaborate within the stroke care and processes at each of our sites. So in 2022, our sites were focused on improving our door to needle times or our door to drug times. And so we started evaluating our code stroke process to see how we could improve those metrics. We used many lean flow concepts to help us organize the investigations, such as value stream maps, A3s, fishbone diagrams, et cetera, for those of you that are familiar with those terms. And it really helped us lay out and identify where we were having barriers in the process. Our evaluation indicated that we needed to call code strokes faster, as well as administer thrombolytic medications faster. Obviously, with having a focus on those door to needle times, we knew we had opportunity there. But both of these pointed to the fact that we needed more robust nursing education around signs and symptoms of stroke, stroke recognition, as well as bedside mixing and drug information. At Hudson, our nurses do the mixing of thrombolytics, and so we needed some more education there because it felt like nurses were fumbling with that a little bit, and so we just needed a little bit more focused education, and then just some general thrombolytic and stroke care education as well.
Yeah, so, Krista and I worked closely together and to try to develop this education program that we're talking about. One of the things that we do want to mention is we did find some obstacles that were presented to us that made our project kind of unique to roll out at this time. We really couldn't move forward with our project without really acknowledging that our nurses had faced perpetual healthcare changes, including surging, staffing changes, personal exhaustion, kind of coming out of those pandemic years. And we really felt a strong need to kind of regroup, pull our teams back together, and develop a kind of cohesive network of stroke care amongst our St. Croix Valley hospitals. So like Krista said, we kind of took a look at our programs and where our common fallouts were and developed a robust education program from there. So as leaders, we felt that we were going to go back to the basics, again, presenting a very clear and simplified process, including really clear guidelines, along with a really like a multifaceted education program. And by having those things clear and rolled out so everyone could access this information, we felt that we'd be successful improving our outcomes. So this education program that we talked about, we developed stroke education that was implemented in all 4 of our health partners St. Croix Valley hospitals, which include Westfields, Amory, Hudson, and Lakeview. It included a lot of information on general stroke care, including ischemic and hemorrhagic stroke education. We did some work with thrombolytic training. We worked on how to perform a neurological assessment as well as a dysphagia screening, as well as inpatient stroke assessments that are required for those of us that keep stroke patients as an inpatient for inpatient care. And looking at the required documentation that's required for that and rolling out education for that as well. We had to use multiple platforms to deliver this information and really reinforce it, including webinars, in-services. We had some virtual presentations that we sent out. We did some video demonstrations and hands-on skill station, and predominantly some online learning modules that we rolled out to all of our staff members. We had a goal of rolling this education out to align with our health partners rollout of Tenectaplace use as the thrombolytic of choice, and that was rolling out as of August 31st. So we kind of had a timeline in front of us to say, let's get this education done. Let's pull together and make sure everybody has what they need to be successful in caring for our stroke patients, and be consistent, I think is the other word I would use, so that we all kind of know what we need to do for our stroke patients across the Valley hospitals. Again, we're kind of reaching out to the different Valley hospitals because we do transfer within our hospitals, as well as, like I said, do a lot of education and program development with our 4 hospitals. So it seemed to make sense to pull us all together. I'm happy to report that by the end of August, nearly 100% of our staff had completed the online modules and virtual education bundles that we had rolled out. We had a large number of nurses attend our live stroke review sessions across the Valley. And like I said, it was a pretty successful rollout of our education bundle is what we use, the word we use. So we were pretty happy with that, that people were very interested in learning more about stroke and refining our skills on how we take care of our stroke patients.
We were overall very pleased with the education that we offered, and we plan to assign it again this year. Our simple project that we thought was going to be very focused ended up growing fingers and becoming a much larger scale project, and really identified other areas of vulnerability. We had great feedback from staff on the types of education delivery options that we offered, and we're continuing to monitor our door to CT times to see what kind of impact our education had. We found that our partnership between Karen and myself with our 2 hospital stroke programs is extremely valuable. And it's really nice to have collaborative efforts in these types of programs that can often feel isolating. We plan to continue our joint efforts between our sites and are excited to tackle further work this year. Thank you.
Thank you.
Thank you, Krista and Karen, for sharing your project and great partnership and the power of partnership, really. Closing out the operational excellence category is Winona Health Services. They are an acute stroke-ready hospital in Winona, Minnesota. Their stroke coordinator, Maria, will be sharing their story today.
Hi, can you hear me okay?
You sound great.
Okay, thank you. My name is Maria Pulowski, and can you go, thank you, to that slide. And I'm Winona Health Stroke Program Manager. We are honored to be a recipient in the Operational Excellence category, which had an emphasis on collaboration. Our PI project was transitioning to Tenectaplace while updating our stroke program as a whole. Next slide. Winona Health is located in Southeast Minnesota. We're designated as an acute stroke ready hospital and called 138 stroke alerts within our ED for 2021. Next slide. Our multidisciplinary QI members were listed in bold here. Some were able to be present in the pictures. Others are EMS and ED staff who graciously volunteered to be a part of our photo. QI members in the left photo included myself, stroke coordinator, stroke program director, Dr. Watrous, and Mary Kay, our IT systems analyst lead. In the photo to the right, our clinical lead pharmacist, Liz, is in far left in the photo. Our informatics pharmacist, inpatient nurse manager, and lead hospitalist providers were equally important to our work, just not available for the photo that day. Next slide. The focus of our project was to safely transition to Tenectaplace instead of Alteplace, while making additional updates to our stroke program as a whole. Next slide. The need for these changes became apparent to us after both Gunderson and Mayo had switched to Tenectaplace we recognized a potential safety risk. A consulting neurologist could recommend tenecteplase, which was acceptable within the department, but our staff were not trained on using it yet for ischemic strokes. Also, we were hopeful making the switch would decrease our door-to-needle times, but realized that this was more than just a simple drug change. Changing the drug required new protocols, order sets, and bedside materials that both providers and nurses use in multiple departments. It was an opportune time to make updates to our entire program, knowing large-scale education was in our near future. Next slide. In February of 2022, our team formed and used a shared work plan to communicate and make progress. Our goals were to safely implement tenecteplase, meaning staff would be well prepared for the change, well educated, have clear protocols, evidence-based power plans, and more efficient nursing documentation. Go live was set for just 12 weeks in May of 2022. This project was successful because of the resources we used. First, we did our research by watching Minnesota Department of Health tenecteplase WebExes. We reviewed past site recommendations, contacted Gunderson and Mayo Stroke Program managers for collaboration, and reviewed American Heart Association and UpToDate for clear, quick guidance. Next slide, please. For sake of time, I can't speak to all the things we accomplished through this project, but would like to give special mention to Bridget Serveus from Mayo Clinic in La Crosse, Wisconsin, whose collaboration led us to implementing this helpful bedside ED stroke alert worksheet. Next slide. The successful 12-week timeline would not have been possible without Bethany Gertler, stroke program manager from Gunderson, who shared all of their tenecteplase implementation materials with us for my own use and modification. Next slide. Nursing documentation improvements were successful because of Donna Lindsay, our last site surveyor, who suggested a simpler neuroassessment build and defined what a post-thrombolytic neuroassessment should contain in her educational webinar. Next slide. It was easy to update power plans using the American Heart Association's 2018 guidelines for management of acute ischemic stroke. Next slide. Educating staff just in time on a large scale was successful by taking advantage of already scheduled skills fairs and staff meetings. Also, Dr. Briggs-Weivelt from Gunderson did his tenecteplase education presentation for our providers at Winona Health. Next slide. Lastly, Genentech happened to reach out to us and share their free resources with us, which we distributed during our educational sessions. In reflection, our lessons learned include 3 things. 1, it pays to reach out to a variety of experts and build off those instead of starting from scratch. Every single person I reached out to helped in tremendous ways. 2, if I had to do it again and had more time, I would have completed continuous system improvement training first and used the methods to guide our project. 3, making EMR changes for multiple departments is always more complicated and time-consuming than expected. Post-implementation, we found some errors that took a lot of time and rework to make right. Looking back, I think using fresh eyes for validating the builds and then piloting the changes first before deploying to all staff would have identified issues and resolved them faster, rather than catching them months later and logging new tickets. And then last slide, please. In summary, our biggest contribution to our success for our project was having a robust team that included multidisciplinary Winona Health staff and collaborating with outside experts such as our neighboring hospitals, MDH and Genentech. Thank you.
Thank you so much, Maria, for sharing how both the operational excellence is a lot of collaboration with different hospitals, and this is a great project highlighting that. Thank you. We will end with the Continuous Impact Award, and this is an award for starting an initiative that created a meaningful and long-term improvement in quality of stroke care. First up is Alina Health Faribault Medical Center. They are an acute stroke ready hospital in Faribault, Minnesota. And joining us today is their stroke coordinator, Sarah.
Hi, this is Sarah Schlicker. Next slide, please. I'm the stroke coordinator at Faribault Medical Center and Owatonna Hospital. Next slide, please. So Faribault is a small city. We're about 45 minutes south on Highway 35, south of the metros. We were formerly known as District 1 Hospital, and we have a significant Somali, Spanish, and deaf community. Next slide, please. So we have a changing population and community in Faribault. The graphic on the left shows our senior population, age 65 and older, who 95% of which have English as a primary language. And the graphic on the right, these are kids aged 5 to 17, and you can see that only 2/3 have English as their primary language. Next slide, please. So our history, in the latter half of 2020, we started seeing improvements in consistency and time to CT despite COVID. But then it got more difficult in 2021, so we modified our log. We worked on consistent feedback and better data to identify what the trends in time to CT were showing us. And then we also began a transition for our acute stroke ready hospital within Alina to a system-wide telestroke program. We transitioned in February 2022 with an ambitious goal of time to CT less than 10 minutes. Next slide, please. So I had identified time to CT as our critical driver, and we identified 3 main issues and some sub-issues. So our first main issue was that CT and CTA were both being ordered immediately after stroke code and then being done and sent together. Essentially, that required an IV, which created some delay, and providers were feeling pressure to have all the answers for telestroke before they talked to them. Our second issue was that RNs were pulling EMS stroke patients into rooms to register them rather than going straight to CT. Once they had pulled them into the room, lots of other things wound up happening, which delayed our time to CT. Next slide, please. And our third main issue was a nursing process that required a full set of vital signs, including weight and blood glucose before going to CT. Essentially, we were doing vital signs and blood glucose on patients who had just had these done en route for EMS patients. And for our walk-ins, we were changing and rooming patients while getting their story and this full set of vital signs, and all of this was delaying time to CT. Next slide, please. So our solutions. To our first problem, essentially we established the primary action for the team to send the patient to CT. Even walk-ins can be sent from triage rather than rooms. Also, our ED providers were encouraged to consult telestroke immediately, and that they would not be expected to have answers, but rather a discussion, including what imaging to order. And finally, and for our second issue, we worked with EMS to develop a new process where EMS would present the ID of the patient to the staff at arrival. Anyone could take it to registration, while EMS truly could go straight to CT. Also, we avoided rooming walk-in patients who had been recognized as having stroke symptoms until after CT. Next slide, please. And for our nursing process, we used the blood glucose from EMS and delayed vital signs until after CT, unless clinical judgment really indicated that they were needed first. We also encouraged nursing to employ a stroke-focused triage. If they were seeing stroke symptoms, they would verify the stroke symptoms, establish last known well, and call the code. Next slide, please. So our goal was to decrease time to CT amidst great change and challenges. We started the year with our door-to-imaging minutes of 24, and the cases that met that within 10 minutes, the percentage was 0. By May, we had achieved an 8-minute average, and we are meeting that goal 71.4% of the time. Next slide, please. So this shows the bar on the left that's orange shows where we were in 2019. The dotted line toward the top is the MDH 25-minute goal, and the dotted line below is the 10-minute Alina goal. And you can see as we worked through this, we were able to bring it down. The last date on there is June 2022. Our October data shows that we are sitting right on that 10-minute goal. Next slide, please. This is just the longer view where we had a great start, then we really struggled in the middle as we anticipated our transition to telestroke, and then we got going, and this goes from January 2021 to June 2022. Next slide, please. Lessons learned. Number one, ask the people doing the hands-on patient care what they are really doing, why they are doing it, and what problems they are encountering. Second, always explain the whys of the preferred process and how this works best for the patient in the big picture of stroke care. And number three, be patient because it is a learning process, but persistent. Next slide, please. Next steps. We need to maintain time to CT. Our challenges are not over. And equity. When examining stroke care by race, we found that Hispanic patients are on par proportionately to their population in the community in stroke care, but African and African American patients are not presenting within the stroke intervention window, demonstrating a gap in our community among a population at higher risk for stroke. So we will need to increase awareness of stroke risks, knowledge of BFAST, and look for barriers to accessing healthcare for these populations. Next slide, please. And finally, again, the team makes the dream work. Faribault has engaged staff dedicated to providing great stroke care, and these are some of our leadership that we want to thank today. And thank you also to Minnesota Department of Health for all of your support for our stroke work. Thank you very much.
So much. Thank you, Sarah, for that wonderful presentation. Next, we'll have for our last presentation is Mayo Clinic Midwest, which is comprised of the Comprehensive Stroke Center in Rochester, Minnesota, and the primary stroke centers in Mankato, Minnesota, Eau Claire, Wisconsin, and La Crosse, Wisconsin. Here to share more about their project is the stroke coordinator from Rochester, Jen.
Thank you. If you want to go to the next slide, there we go. So this is our project team members, was the 4 stroke coordinators in our Midwest Mayo practice. You can see this was actually a picture taken at the stroke conference up in the cities this year. Go to the next slide. So we really noticed that we had kind of this 3 or 4 year period where the primary stroke coordinators primary stroke centers saw frequent turnover in their stroke coordinator roles. So 2 of our sites went through a number of stroke coordinators in a short period of time. And so we really wanted to try and identify what were the barriers, what was going on, and how could we get people in those roles and stay in those roles longer. So we identified contributing factors through interviews and informal and formal conversations with the stroke coordinators who had vacated those roles to try and figure out kind of what the barriers were. So kind of the initial items that came up was that there was really no formal orientation set up at the separate sites for being a stroke coordinator and what that role entailed, how to do all the different tasks and such related to that. There were no formal preceptors since each site only had 1 stroke coordinator. There wasn't someone else in the role to precept them. Really lack of resources surrounding the whole role. A lot of feelings of isolation and being solely responsible for a large program without having that support needed. And then a big lack of support with accreditation visits. So a lot of these people came into their role, had a visit right away, and really didn't have a lot of support or knowledge of what was going to happen during the visits, and then support afterwards to implement changes. Next slide. So some of our goals and interventions. So one of our first ones was to really develop a formal primary stroke center stroke coordinator orientation plan, and then have other stroke coordinators identified to help precept with ongoing mentorship. So we developed a formal orientation plan for the primary stroke center coordinator role. That plan was formatted in kind of a, it's called a TSAM model. So it was different tiers. So you kind of worked through one tier, became more competent in those items, and then you'd move to the next tier. So it might be learning about the stroke coordinated role, learning about the different measures, learning how to track your patients, and kind of moving up to doing all your data and performance improvement plans and being able to manage your whole program. So kind of a step-by-step approach. Then we identified that preceptors from the other centers would be helpful to be utilized. So frequent meetings were set up weekly. We'd go through the TSAM model, We discussed stroke issues, things that came up, answer questions, and kind of help mentor them. I think one thing that actually was really helpful was the pandemic, because we really learned how to leverage those different modalities that we could be meeting with, whether it was via Teams or Zooms or phone meetings, just so that we could share screens and do things remotely without having to be sitting right next to that person. And then we also, one of the big parts of the project was really standardizing the role of the primary stroke center stroke coordinator between those 3 sites. So looked at what were they doing daily, what did they do with their visits, what data standards are they monitoring, what additional data, how are we collecting it, where are we collecting it, so that all those things were kind of standardized, which makes it much easier to orient someone, to be supportive later, to answer questions when all 3 of them are doing the same, a very similar role. That also came with doing some standardization of practices between the sites, which we already had a pretty good start on in our system, but just kind of finalized some things that were specific to the primary sites. One of the other goals was to provide on-site support during those Joint Commission visits. So coming into a new role and then not having been through a visit, it's really helpful to have another stroke coordinator there to help guide you, answer questions, especially with the standardized practice. It was easy to kind of step into those. So we now make sure that there's at least one, if not 2 of the stroke coordinators from a different site there on site to help, whether they're sitting in a conference room able to help pull policies or doing chart reviews, or if they're walking with the surveyors to help answer questions, so that we can all support each other throughout that. And then once citations and recommendations are received, we work together as a group on those to implement the things at all the sites, to see if the gaps are across the sites or just in one location. And then really the main goal was to become a cohesive Midwest stroke coordinator network so that we could rely on each other and use each other every day. So we now meet formally monthly as a Midwest group and monthly as an enterprise group with our Arizona and Florida colleagues. And then we are constantly in communication all day, every day via Teams and email. And we have a central folder that we use for project and practice standardization documents. Next. Some of the successes and lessons learned, collaboration and standardization definitely has saved time, improved cohesiveness, and provided a lot more support to all 4 of the sites in the Midwest. Having a formalized orientation plan and now having 2 stroke coordinators who've gone through that, who have now been in their roles for a little bit, was super helpful. We did kind of PDSAs where we modified things to make sure that we were getting everything that we needed. So if we missed something, we go back and add it so that it's there for future as well. And then the biggest thing was that on-site support during the Joint Commission visits has drastically improved satisfaction and feelings of being supported. So you may have amazing stroke teams at your site, but nobody else really understands the details of what goes on during the visit, what all the standards are, how to navigate the record quickly to look things up, because we're kind of doing those things all day, every day. So that's been a huge satisfaction implementation item. And then kind of next steps is we're working on a similar project with our 9 acute stroke ready sites to standardize care, build relationships, and share documents, resources, education, et cetera. So a little different lens than what we did for this one, but really trying to pull those 9 sites together and make them more cohesive and supportive as well.
Thank you so much, Jen. This went along with the theme of supporting each other, but this one was strictly focused on the stroke coordinators, which was really neat to see how you all approached the project and thought out a plan and to see what's the next steps. Thanks, Jen. So before we wrap up, our stroke program director, Nikki Anderson, would just like to share a few words.
Hi, everyone. Thanks, Allie. I just want to jump in here and let you all know this is really impressive work. And I want to thank you. Thanks for not only doing this great work, but sharing it with everybody here today. And we're so proud of you for what you've done and these quality improvement projects. As Allie mentioned earlier on the call, we encourage you to continue to consider applying for the program in 2023. Something seemingly small can have a significant impact, and these are great opportunities to learn from each other. So thank you again. Great work, everyone. And we can't wait to see what you do here in 2023.
Yes, thank you for joining us today, and a huge thank you to our presenters for sharing your project, your knowledge. I know there's a question about sharing forms. We will connect you to the stroke coordinator for that. I just put the survey link for contact hours in the chat. I hope today leaves you feeling inspired and wanting to connect with others for around quality improvement. For those stroke coordinators wanting to continue this at a primary or comprehensive stroke designated hospital, there's the Minnesota Stroke Advisory Group that meets regularly. For more information about that, please contact Nikki. And then for acute stroke coordinators, if you're not already part of it, you can join at any time the Minnesota Acute Stroke Ready Quality Improvement Collaborative. Our next meeting is on January 26th. An invitation will be sent out this week, so please reach out if you're not already part of this group, but you're interested. This group is just for acute stroke ready hospital stroke coordinators, so it's just for you all. Lastly, if more questions come up about today's presentation or questions for another stroke coordinator that presented today, please email us at health.stroke@state.mn.us and we can connect you and general questions we'll share in the follow-up email. Thank you so much for your time and thank you all the presenters again.